We have our last speaker coming up, Alicia. She's a biotechnologist with a master's in biomedical sciences from the University of Lausanne, specializing in clinical bioinformatics. With 4 years of experience as a bioinformatician at a hospital and a data science internship at Roche, she's now a PhD candidate researching drug synergy prediction in organoid models using deep learning with prior work on genetic landscape in sarcoma and homologous recombination repair. Thanks a lot for being here, Alicia, and the screen is yours.
Thank you so much. First of all, can you see my screen? Everything works?
Yes, we see
nice.
it. Yeah.
Nice. So thank you so much for the invite. And I'm very happy here to present my PhD work, which is mainly funded by the 3R Competence Center. And my work is called AI-mediated, which is an artificial intelligence model that predicts drug synergy. And I will also further quickly present the validation strategy in patient-derived tumor organoid models. So I would like first to give an introduction to the personalized combination therapy. So as you have already heard in this webinar, we have been treating patients in a one size fits all. So this means that patients belonging to the same cancer type with different molecular profiles were treated by the books and given the same therapy. And we have moved now at the hospital towards a personalized monotherapy in which, thanks to the advances and progresses in next generation sequencing, we are able to molecularly characterize every single patient. And if there is availability, we are able to give targeted therapy to target these specific mutations. However, this personalized monotherapy has its caveats, such as, for example, producing drug resistance and also safety concerns, so toxicity. So our aim is to move towards a personalized combination therapy. And for that, I show here on the right-hand side a timeline from the latest publication in which we had a patient here in the hospital, which was diagnosed in 2020 with progressive disease of leiomyosarcoma, which is a very rare type of sarcoma. And this type of leiomyosarcoma didn't have a treatment. So this patient was given with doxorubicin. And after a while on doxorubicin treatment, he was performed with a genetic test, in this case, with Foundation One medicine test. We only found one mutation in TP53. However, we were able to find some biomarkers such as the LOH, the loss of heterozygosity, which is a biomarker for homologous recombination deficiency. So this allowed us to find a combination for olaparib and trabectedin, which was given to this patient, and after a while he stabilized and he could survive for more months. This combination therapy has some advantages, such as that it reduced the drug resistance. It also increased the efficacy, and we are able to give the drugs in lower doses, so it's also lowering the secondary effects and therefore also improved safety. And how we integrate this into the clinics here in the functional tumor pathology lab at the University Hospital in Zurich, we have developed a comprehensive workflow combining molecular profiling and functional profiling. So here I won't explain in details because George has already done it before in the presentation before. But when we have a patient with a tumor, the pathologist here in our department diagnose which type of tumor it is, and we send it for sequencing, able to recognize or to find the mutations from this patient. And at the same time, we are able to culture these patient tumor cells into organoids and perform functional profiling. At the moment, we have an automated functional drug screening platform, and we are able to find out drugs that would work in this specific tumor organoid. And as I said, we would like to move towards a combination personalized therapy, but as you can imagine, this would involve a lot of trying new combinations. So this would be this would be time consuming, and this would also be costly. So in order to reduce these variables to make something more efficient and cheaper, we propose the AI Predict, which we would aim to do or to develop a deep learning algorithm in order to predict the drug synergy combinations, incorporating the structures and the features from the drugs and the patient genomics. And this would allow us to repurpose also drugs that are already existing and that have already been approved and clinically validated. After finding the best drug combinations, we would like to incorporate a drug-drug interaction prediction model, which would allow us to exclude the interacting combinations. And after having that in also making use of all the cells we have from the hospital and the biobank, we would like to validate this first in cells and secondly in organoid models. And how these projects contribute to the 3R principles in the different layers of the process. As I said, we would like to predict the combination, the best drug combinations, and this would allow us to repurpose drugs that have already been approved and are already there to use, but they don't have a specific disease, for example. So this would allow us to reduce, replace, and indirectly also refine the use of animal experiments by reducing the clinical development process. Also, with our drug-drug interaction prediction, we could contribute to the replacement of animal experimentations using toxicity studies. And by using also our patient-derived organoid models, we contribute to the replacement, since our organoids, patient-derived ex vivo organoid models, resemble the patient, the same patient genetic profile. So how do we plan to do that? We have already a model, and what we are focusing is on predicting synergy. And how do we measure synergy? There are different models and different ways on how to measure synergy for the drug combinations. In this case, we have decided to go for the Synergy Finder, which is a software that it gives you the scores for four different models. In this case, it's HSA, Bliss, LOEF, and SIP. And why we decided to go with this approach? Nobody so far has combined different scores in a prediction model, and the reason for that is quite of a complex problem. There is no agreement on which synergy score should be used. The only agreement so far is the Seri-Selka from 1992, which proposed that LOEF and Bliss are the standard scores. However, it's true that these scores have also been reported in later publications to have some caveats, and newer scores, newer models have also been developed. So for that reason, we decided to use Synergy Finder, which is this software allow us to compute 4 scores and combine the 4 of them to have a better prediction. So the inputs of my deep learning algorithm are the labels, so the labels of the synergy scores. So for each of the 4 synergy scores that I have mentioned before, we binarize them in 0 and 1. So if the synergy score is below -10, is an antagonistic combination, and if it's above +10, is a synergistic combination. And everything between -10 and +10 is additive, and for this model was not considered, but it's something that we would like to consider in the future. Regarding the drugs, we have incorporated the SMILES of the drugs and 9 different features. And for the cell representation, we have incorporated 1,000 landmark genes, which is a representation of the whole transcriptome based on this publication from 2017. And the data set that we have used so far is the biggest data set for drug combination, which combines 24 different data sets, and it has an overall of 1,432,000 samples of combination triplets, drug A, drug B, and cell line. And I will go just a little bit in detail of our model, which the model that we have developed so far, thanks to the collaboration with Michael Krauthammer lab, also here at the University of Zurich, is DDoS, is a graph neuronal network based drug synergy prediction algorithm. It was published this year in the Conference on Health Inference and Learning. And it is composed by the inputs here. The inputs are the ones I previously mentioned. So we have the two drugs and the cell line gene expression profile. The drugs are incorporated as graphs. So we have the SMILES, which is the drug representation here, in which each node represents an atom, and each edge represents a bond. And this is represented into two different matrices by its drug. And the cell line is a linear vector of the 1,000 genes. So this information, this drug information, is given into a graph neuronal network with different layers and attentive pooling. And this is going to output the best feature representation for each drug. And the gene vector is rescaled, and the output, so of the two best drug representations plus the gene expression feature, is concatenated. It's fed into a feed-forward network with a log softmax, and this predicts which combination is synergistic and not. The results from our model are here outlined in the table below, and we compare to different baseline models, and we use 7 derived data sets. So we use an individual data set. We train the model into individual data set for each different score, and we also use a majority voting approach, in which, since I said we divided or we classified the scores into 0 and 1 based on if it's synergistic or not, the majority 4 would be, for example, if four of these scores were 1, so both four of them were synergistic, and the 3 is if 3 of them are synergistic, and 2 is if 2 of them are synergistic. And of course, the one that has all the scores synergistic would be a little bit more biased towards synergistic scores. So yes, and we had our graph DDoS, graph neural network DDoS model, which outperformed the rest of the model compared to the baselines, also with the KNN and regressions, etc. So this, having said that, we are moving now into a validation plan. So we have divided the validation into 3 different phases of validation in vitro. The first phase would be to test the model on drugs and cell lines that are known by the model, but in different triplet combinations. This is an ongoing process that I started a couple of weeks ago. And if this phase 1 is successful, we would move to phase 2, which would be to evaluate the model predictions on cell lines that are not known by the model, so that are not in the training, and also so either or. So either cells that are not known by the model and drugs that are known, or the other way around. And for phase 3, we would like to validate the model predictions on both unknown cell lines and unknown drugs, and preferably using organoid models. And to conclude, so we have this nice model, but of course it has also its limitation, and we would like to implement it using drug-specific concentration, so that we are able to go beyond and be more precise. Also to ask regression tasks, so that we can tackle the bias towards synergistic combinations. And we will need to implement the downstream drug-drug interaction model, which we already have from another PhD that developed it. So we would like to include it downstream of the model. And of course, finalize the validation in the cell lines and the organoids. And with that, I come to an end, and I would like to acknowledge my team and my collaborators, and of course the 3R for funding my PhD. And thank you so much for your attention.